executive leads. You have access to her biography, so I'm not going to go into all the detail, but she's a member of our team over at the Bradford Institute for Health Research, and also an academic, visiting academic over at the University of New South Wales in Australia. And Jude does work on supporting healthcare professionals and on around well-being and burnout, and also exploring how to communicate more effectively and compassionately within the NHS. So Jude, I'd love to hand over to you now to introduce your colleagues and the session. Thank you.
Thanks, Rebecca, for that wonderful introduction. So I guess now to me. So when Rebecca was asking for topics for the seminar series, I immediately thought of Kevin and Helen, and I wanted to hear more about their work. And I was so delighted when they said that they could join us today. So just to introduce, first of all, Kevin. So Kevin is a consultant urological surgeon and a visiting professor at Bournemouth University. His clinical interests are in urological cancer and robotic surgery, but more importantly for our purposes, in 2015, he co-founded the Bournemouth Surgeon Wellbeing Research Team at Bournemouth University. The team aims to understand the impact of adverse events on surgeons, but is more generally also researching surgeon wellbeing. And I think most recently, or a real flourish of the work of the team has been the production of the Good Practice Guides, their Royal College of Surgeons Good Practice Guide, supporting surgeons after adverse events. And we're also joined by Dr. Helen Balderston, who is a consultant clinical psychologist by background, but is currently based at Bournemouth University as a principal academic in psychology. Helen's an expert in acceptance and commitment therapy, but she's also a member of the Bournemouth University Surgeon Wellbeing Research Team, and as part of this work, she has led an RCT testing a resilience-enhancing intervention for trainee surgeons. So I am really excited to hear about the presentation that you're going to share with us now. I'll hand over to you.
Thank you. Right, I'm just going to share my screen. So it was really lovely for us to be invited to speak today. And so, yes, we're going to talk about, Kevin and I, between us, are going to talk about one aspect of our team's work. So this is our team. We're very small. We're a mixture of academics, clinicians, and we have 2 PhD students at the moment. So we're going to talk about the impact on surgeons in particular of adverse surgical events. So what I'm going to do is give you some background information and some context to give you an idea of why we decided it was vitally important for us to try and do something to help surgeons in the aftermath of adverse surgical events. So I'm going to give you some of the background, and then Kevin is going to tell you what it was we decided to do and what we have been doing as a team. So by way of background, this is a research paper that we had published in the British Journal of Surgery earlier this year, and it's based on a fairly large scale online survey of UK surgeons. So about 450 surgeons completed the survey, and we asked them a lot of questions, just general questions about who they are and what they do and how they are, but we also did something that, as far as we're aware, hadn't been done in quite the same way before, which was to randomly assign participants into one of 2 conditions. So either for them to recall and think about an adverse event that they viewed as an error they had made, or the other condition was to think about, to recall an adverse surgical event that they viewed as a known complication of that intervention. And so we asked them to think about what happened to them kind of emotionally, psychologically, following that event that they focused on in the research. So I'm just going to talk you through some findings. So it's a really big survey. We're writing up a second paper at the moment, so I'm not going to, certainly don't have time to talk you through all of the results, and I don't think that would be particularly interesting. But what I will say is we did ask our surgeon participants, first of all, about the impact of the adverse event on their physical health, and we asked them about things like headaches, gastrointestinal issues, cardiovascular issues, and so on. And it looked like that there were kind of modest negative impacts on physical health of experiencing these kinds of adverse events. But what was much more striking was the impact in terms of mental health and well-being variables. So that's what I'm going to focus on. So this table basically lists a series of mental health and well-being issues we asked them about. And if we focus on the column, first of all, that's headed whole sample, so this is our whole 450 surgeons. The figures in brackets are percentages of the whole sample. So this is the percentage of respondents who said following this adverse event, either this problem started for the first time or there was a significant increase following the event. So for our sample as a whole, over 40% said that they had a significant increase in sleep problems. Almost 50% said that they were experiencing anxiety. A third were experiencing anger or irritation. So there was a lot, they were reporting a lot of increased struggling and suffering following an adverse event. I'm going to come to the bottom row that's labelled PTS scores in a moment. That's slightly different, but if we stick with the other issues for now. And then because we randomly assigned people into either focusing on an error or focusing on a complication, we were able to compare what those two subsamples are telling us. And so what we found was that for several of these mental health variables, there was a significant difference in the numbers who were saying, yeah, I had a significant worsening of this issue. And where there was a difference between the two conditions, it was always in the direction of the people who were focusing on an error saying that their experience was particularly bad. So we had a greater frequency of sleep problems and depression and so on in the error group compared to the complication group, which is, perhaps not surprising, but we're not aware of a great deal of research that has systematically looked at this issue before. And then if we look at the row along the bottom, PTS scores, so this is post-traumatic stress. So we used a really short post-traumatic stress screening measure. It's typically used in general practice. So this is not about diagnosing PTSD, but one of the features of this screening measure is that it has a cutoff point. And if you score above the cutoff point, that's indicative of clinically relevant levels of post-traumatic stress. So kind of levels of symptomology that really is worth paying attention to. And so the percentages aren't in this table, but what I can tell you is that the error subgroup, so the surgeons who were telling us about what happened to them following a surgical error, just over a third of them told us that they were above that threshold. And just over a quarter of the complication subgroup were reporting sufficient post-traumatic stress symptoms that they were of kind of clinical relevance. So, altogether, this is, this represents a lot of suffering, a lot of surgeons really kind of impacted by their experience, their involvement in errors and complications in surgery. And then just another couple of pieces of information that the respondents to the survey shared with us. On the whole, the surgeons felt ill-prepared by their training for dealing with adverse surgical events, not ill-prepared in terms of being able to deal with them surgically, but ill-prepared as human beings with feelings. And then the finding that it kind of breaks my heart whenever I think about it is that the sample as a whole, over 40% of those surgeons never talked to anyone about the adverse event they were involved in. So perhaps a patient died on the table, or there were, significant, devastating impacts of something that happened in surgery, and 40% told no one, talked to no one. And of those who did talk to someone, mostly they talked to colleagues or a partner or friends. And very few who did talk to anyone accessed a formal support service. And that fits in with what we know from other published data. So, for example, Physician Health, who you may well know, provide a UK-wide high quality support service for doctors. From their data, surgeons are very poor users of their service. They're very underrepresented in their data. So we have this picture of many surgeons being really adversely affected, but perhaps being quite isolated. So to summarize the kind of the background, the context I want to give you is, I mean, obviously we have the data from the survey, but as a team, we have a lot of contact with surgeons. So for example, a few years ago, we ran a small one-day conference focusing on supporting surgeons when things go wrong. We had about 50 surgeons attend. And we heard many very sad, very moving stories from surgeons. And what they were telling us in person absolutely fitted in with what they were telling us via the survey, which is that surgeons are significantly negatively impacted by adverse events, particularly errors, but not only errors. And I would say, as a little aside, that if you think about surgical errors and complications as being on a continuum, then obviously there are some events that are absolutely at one end or the other, and it's very clear this is a complication or this is an error. But there's a lot of grey area in the middle where it's not quite clear to what extent the event was an error or complication. But what we do know is that when surgeons view what they did as a personal error that they made, that seems to be particularly problematic in terms of the psychological suffering that they experience following that event. So we also know that these negative effects can last for years, decades even. We've certainly spoken to surgeons who have become tearful, telling us about something that happened in surgery, a decade prior to us meeting with them. And we know that they're poor seekers of support. And we also know that they're often treated very unhelpfully by their employers, their NHS trusts and other employers in the immediate aftermath of adverse events. So for all of these kinds of reasons, as a team at Bournemouth University, we felt it was important for us to try and do something to intervene, to try and make this, try and improve the lot of surgeons, particularly in the immediate aftermath of adverse events. And so I'm going to hand over to Kevin, who's going to tell you what we did and what we have ongoing at the moment.
Thank you, Helen, and good afternoon, everyone. It's a real delight to join you and be part of your seminar. I'm going to use the rest of our bit of the presentation to talk about some of the post-event work that we've done. We had some minor technical problems, so you have to forgive me that I'm going to have to ask Helen to advance my own slides, and I'm sorry about that. Helen's laid out the background just about the impact that adverse events have on surgeons. And I think when we began to talk about this, we were, I think inundated is the right word, with messages, emails from surgeons who basically wanted to say to us, thank you for doing this work. Let me tell you about something that happened to me. And this is typical of the sort of thing that surgeons said to us. I felt and feel very guilty, but I remain disappointed by the lack of support from my employer. I felt I was treated like a criminal first rather than any duty of care to me as an employee doing his job. I found it very difficult to talk about at home. It was only the support of my colleagues that enabled me to get through that period. Thanks, Helen. Here's another example. I don't think the institutions have any knowledge of the difficulties that their consultants face. And to my knowledge, there are no mechanisms of support at all. If a surgeon mucks up, the trust response is to suspend them. Probably skip the next one, Helen, thank you. So we thought we've got to do something about this. And one of the nice things about doing work in a space where there really is nothing is that anything that you do might be better than what's there already. And so we set about trying to put together a group of interested people. These are some examples of who we gathered together. Psychologists, NHS managers, the Doctors Trade Union, the BMA, NHS Practitioner Health, which Helen has said is a national mental health support service exclusively for doctors, one of the largest of the medical indemnifiers, the Medical Defence Union, representatives from the Royal College of Surgeons, interested surgeons, and we convened a series of round-the-table meetings under the acronym SAFAR, Surgical Adverse Events, First Aid Response. And what we essentially said to these stakeholders is, from your professional position, what do you need from a surgeon in the aftermath of an adverse event, which perhaps is a very important question if you're a defence organisation, but a parallel question, what can you offer to a surgeon in the aftermath of an adverse event? And from various roundtable discussions, we co-authored the document you can see in front of you, Supporting Surgeons After Adverse Events, which was jointly published by us and RCS England right at the end of 2020. And it's part of the RCS England's Good Practice Guide series, which they release 2 or 3 a year. And it lays out some best practice in terms of supporting surgeons after adverse events with what we hope are is some helpful guidance about how trusts particularly and surgeons as individuals might navigate this situation. Thanks, Helen. And I guess our document falls into 3 main parts. We review what's known about the impact of adverse events, and Helen's covered much of this from our own data, and we pulled in some of the data from other sources just to summarize what was known. Thanks, Helen. Then we covered some particularly pertinent issues that had come up from people who had corresponded with us. We looked at various aspects of self-care. We looked at what characterizes a responsive and caring employing organization. We covered some of the regulatory and medical legal issues that arise in the immediate aftermath of an adverse event. And we also put some focus on a couple of particular groups. Many surgeons are involved in private practice, and the issues are perhaps the same but worse in private practice. Expectations of surgeons are greater, institutional support is less, publicity is often greater after adverse events in private practice, and also doctors in training who form a really interesting group within our group of surgeons with additional issues. For example, doctors in training often worry that if they are too public and open about their experience of an adverse event, that somehow that becomes a label applied to them in their training and is carried with them when they move on to the next centre in which they train. That's one example. Another example would be doctors being trained by an experienced surgeon, and that when something goes wrong, and that sets up a very interesting and potentially difficult dynamic for both parties involved. And I think the most striking thing about this aspect of our work is just the stunning vacuum that appears to exist in terms of lack of response from organisations which employ surgeons. And most surgeons told us that trusts were good at fulfilling their statutory responsibilities, duty of candour, and serious adverse event investigation, but were really unaware of how to care for surgeons. And we heard some extraordinary things about people, for example, going home on gardening leave without any advice about how and when they should return, what sort of work they should do, with what level of supervision. And responses range from, you've just got to get straight back into the theatre and get operating again, through to, we're not sure you're safe to operate at the moment. And surgeons weren't helped through that process. And so out of our roundtable, we felt that there was room for a new role. We called this role a surgeon first responder, but it means essentially surgeon to surgeon peer support. And I'm really happy to explore maybe in questions why we feel it needs to be surgeon to surgeon peer support. But I guess part of our thesis here is that there are some unique or nearly unique aspects about surgical practice that means that it needs to be a surgeon talking to another surgeon. And the key point about the first responder role is that it is separate, both practically and bureaucratically, from any formal response from the trust in terms of investigation, duty of candour, sanction of a surgeon's practice, and solely focuses on surgeon well-being. Thanks, Helen. So we spent some time debating who the first responders should be. We felt they should be a surgeon with a minimum degree of experience, with some requisite personal characteristics that enable them to be appropriately empathetic, that they should be completely independent clinically from the event, that they should be local, and that they should have a degree of training, so that they should be taught how to do some of this. And just as an aside, surgeons have spoken to other surgeons about adverse events since the beginning of surgery, and you don't need to spend long in a surgical coffee room to hear surgeons talk about something that happened to them. And there is some kind of built into surgical culture, some response which is at least partially helpful, and that response is something like, that sounds terrible, let me tell you about something that happened to me, and often it's made to sound a bit worse, and what you need to do is get back on your horse and you're good and get back in the game. And we realize that while sometimes this is helpful, often it isn't, and that with a modicum of training, and we're not talking about making people into trained counselors or psychologists, but with a modicum of training, this can be done better. Thanks, Helen. We spent a lot of time talking about whether this should be mandatory. Surgeons are rubbish at engaging with what exists already for all sorts of reasons, which we could explore. We actually fell short of mandatory, but we do feel that this should be a default response. The kind of culture we would like to have in and around operating theatres is, we heard that something went wrong. We don't know if you have been affected, but because there is evidence of incident, that's enough to press the start button on the first responder program. We don't need evidence of harm. We just need evidence of incident. And because we have good data on how surgeons are affected when things go wrong, we want to have a chat to you about it. So not mandatory, but default. It should be soon, confidential, kind, focused on well-being, with the ability to signpost to existing support mechanisms where that initial meeting requires that. And we developed a very simple checklist to help the supporting surgeon work through, and these are some of the things that the first responder interaction needs to include. What happened? What support do you have already? Are you able to work, and in what context? And you can see the other things there. But we realized in the emotional turmoil after an adverse event, many of these things get overlooked, and surgeons are not prompted by existing mechanisms, and we felt that the first responder interaction should at least be able to direct surgeons to these aspects. Thanks, Helen. So where have we got to? Well, this kind of work takes time. In Bournemouth and Poole, where I work, which is a combined trust, a very large district general, we have trained our first cohort of surgeon first responders. Helen and I did it together. We did it in half a day. We trained surgeons across specialty, and we taught them, we think, how to do this better. And the surgical first responder program is live in the trust in which I work. Every surgeon and anaesthetist is aware of it. And we are about to run some training, Helen and I, in a large London trust in 2 weeks' time, where we're going to teach surgeons in that trust about the program. One of the surgeons who I admire is a surgeon called Peter Yu, who works in Stanford. He said, no other profession which demands elite performance has dedicated so little to the support of its practitioners. I do not think it's unreasonable that we should have surgeon-to-surgeon peer support in every trust where surgeons are employed. Thank you. Thanks, Helen. So very briefly, these are the people on our team who contributed, and to them we owe a great deal of thanks. And I'll leave it there. Thank you.
Thank you very much, Helen and Kevin. And we'll move swiftly on, I think, now to Jude's talk. Please do pop any questions or comments that you've got in the chat now and throughout Judith's talk. Thank you.
Okay, I think I'm unmuted, so I'll get started. So I'm today going to be talking about the Reboot coaching program, which is a prophylactic intervention to prepare healthcare professionals for adverse events. So there are three main reasons that we created Reboot. So the first is that we have enough evidence now to know that patient safety incidents are so common as to be almost definitely going to happen in a healthcare professional's career at some point. The second is that we know that the sequelae of these kinds of incidents can be really terrible for healthcare professionals. And then the third is, up until Reboot was created, there was no prophylactic intervention that had been tested to see if we can prepare healthcare professionals for these incidents. So I guess just to give a bit more information about the kind of incidence rates of patient safety incidents. Oh no, that's not going well. So there, 1 in 20 patients are exposed to preventable harm. 12% of harm causes permanent disability or death. 10 to 15% of healthcare spending is on direct sequelae of preventable harm. And foundation doctors are at the highest risk of making a mistake, but all doctors can make mistakes. And this was a review just on doctors, so I think we can extend that out to all healthcare professionals. So there is this myth that you can grow out, you can develop yourself out of making mistakes, but all the evidence suggests that that doesn't happen. And the reality is that mistakes get made and they can happen at any point. So, as Rebecca said before, at YQSR, we have a long history as a team of researching into the emotional impacts of patient safety incidents. But broadly speaking, the impacts are emotional, physiological, and behavioural. So emotionally, healthcare professionals report feeling guilt, shame, loss of confidence, anxiety, and low mood. And this can have physical impacts. So sleep problems, exhaustion, loss of concentration are all things that healthcare professionals regularly report after an incident. And it can also, in the longer term, impact how a healthcare professional behaves. So they can begin practicing defensively, like ordering more tests, being overly cautious, actually to the detriment of patient care. It increases the risk of future errors. It can lead to relationship disruption, both between colleagues and also in a healthcare professional's personal life. And sometimes we hear from healthcare professionals that they begin avoiding things, which isn't really good for great teamwork. And in very worst case scenarios, people have reported leaving the profession after an adverse event. So it was these things that led us to create Reboot, because if patient safety incidents are going to happen and they're going to be horrible to experience, we need to prepare healthcare professionals before they do, so that it's not quite such a shock, and so that they already have strategies in mind which they can go back and draw on. So when we created Reboot, we were really keen to make it work. So psychologists, of course, what we did was we looked to theories and evidence, things that already had evidence that we could draw on to help our intervention be have the best chance of working as possible. In particular, we drew on cognitive behavioural therapy because it's the most evidenced psychological intervention anywhere in the world and the most frequently delivered by the NHS. We thought that was a good bet for techniques. And also we drew on psychological resilience theory, which is a huge field of research when creating Reboot. Now, of course, the problem that we had in around 2017, 2018, when we were creating Reboot, is that resilience became a very unpopular topic. It had been adopted by a few organisations, kind of almost as a bit of a stick to beat healthcare professionals with. So in a context of underfunding, this idea became popularised in some circles that if we can just make our healthcare professionals more resilient, then we don't need to fund services better. They'll just keep working harder despite everything going on around them. So what we always say when we deliver Reboot to the people that are coming to our workshops is that that's not our view, that's not our conceptualization, that's not our approach of resilience. That actually the way that we approach resilience is very much the psychological way, not the health services way, and that our concept of resilience is developed from decades of psychological research into what makes people feel better when things are going wrong. So it's not about making people work harder despite an underfunded healthcare service. It's about helping people to feel better when things go wrong in their work or in their life. In particular, we give this example. So we say, for example, we know that when people are facing risk factors like a bullying boss or an adverse event, it increases the risk that they're going to have negative emotional outcomes like depressed mood. Our concept of resilience is that it's something that comes in here, that if we can help you develop some psychological strategies, which we call resilience, then in the face of risk factors like a bullying boss or an adverse event, you're not going to feel great. No one feels great in response to that, but you'll be able to employ strategies and do helpful things that will mean that you'll be feeling okay. You'll be able to move on from that. So we took psychological resilience theory, particular framework for understanding psychological resilience, and we did a systematic search of all the literature that's ever been published, all the studies that have ever been published, which tell us, which have investigated the psychological factors which help people to feel less down after a failure event or a mistake. And from that, we found 3 consistent psychological factors that came up. So the first was that higher self-esteem, more positive self-beliefs, help people to feel less bad in response to a failure event. Second, having a better way of understanding and interpreting negative events was consistently helpful. In psychology, we call that attributional style, but I don't think that's really a real word used in the real world. There we go. So this is the way that we explain it. It's about how you interpret, how you explain things that go wrong. And then the third resilience factor that kept coming up as being useful at buffering people from the emotional impacts of failure was having higher mental flexibility, which is the opposite of perfectionism. So having less rigid standards and being able to flex and adapt when things are difficult. Now, we've completed 2 studies of Reboot. The first study was pre-COVID, and we delivered this in a sample of 66 healthcare professionals of different disciplines, including student groups. Now, at that time, Reboot involved a 3.5-hour in-person workshop and then 1 60-minute coaching phone call that was always done over the phone, never on Zoom or Teams, because it was before people got familiar with Zoom and Teams. And the intervention itself, I guess, just to say, is we adapt it for every group that we work with. So we have a workbook of materials that involve case studies, which relate to specific stressful events that healthcare professional may encounter in line with their work. And the intervention, as I said before, is based on CBT and resilience theory. And this version, it was Ruth, who's an occupational health psychologist, who's here on the call today, and I that were delivering all of the workshops and the coaching phone calls ourselves. And it was just single arm, we didn't have a control group. But what we found was that at follow-up, there were significantly high levels of psychological resilience and confidence in coping with adverse events, suggesting that Reboot was feasible, it was acceptable, and it was potentially effective for increasing resilience. And I just need to thank Kathy Box as well for this particular slide and a couple of the others that are coming up. So these were our findings on a graph. And when I saw this, genuinely, I was stunned, because I just didn't think that an intervention as light touch as the one that we had delivered would be able to produce these kinds of results. So it was fantastic to see these results, and I was delighted with the statisticians' work on this. So what we found is, as I hoped, this was the one I hoped would come out, that people's knowledge about resilience increased before and after attending the workshop. So that was a significant increase. We also found that people's confidence in coping with adverse events increased both from before the workshop to after the coaching call, and even to 4 to 6 weeks after baseline. So that increase, it came immediately after the workshop, and it was maintained over time. And then finally, the one that honestly really stunned me is that through this very light touch intervention, people reported significantly higher levels of resilience. So we didn't measure this after the workshop, but we measured it after the coaching call, and then 4 to 6 weeks later, which is really kind of lasting results from something which is quite light on time. And the qualitative results gave us some really useful information as well. So the first one which came out, because we did it in a range of groups and we did it in students as well as qualified healthcare professionals, was that qualified healthcare professionals seem to get more out of it. So we know from the stats that they were less likely to drop out, and it seemed that from the qualitative research that this was because they related to it better. So this midwife said, I related it to me, related it to real life. You know, as I said, all the case studies that we've discussed, I've been through, I've done it. Another thing that came out was, I guess, that the combination of a peer workshop with a one-to-one coaching call seemed to work really well. So in terms of the peer engagement, people liked talking to their peers. They liked sharing that. They liked that kind of catharsis. They liked checking in and knowing that they weren't the only ones who have experienced things. And also because when we did it in person, people often knew each other. They were coming from the same place. There was often a lot of encouragement and a kind of peer support that came as well. That was just really nice to see. So this OBS and gynae trainee said, it encourages discussion points, doesn't it? Plenty of time to discuss what was your view, plenty of chance to kind of interact with the facilitator and the other members of the group. And then what we found was that then adding a one-to-one coaching call on top of that just helped people to really understand what it was we were trying to support them with. So this paramedic said, I found the follow-up phone call personally very useful because I learned things about myself that I hadn't even considered. And it's my view that either one of these in isolation is not as nearly as effective as the kind of synergy between the two. And I think that's also what's coming out through further research that we're doing. Sorry, I've got a bit of a cough. Okay, so the next study, the one that is finished but not yet published, Angela Grange was the PI on this one, and Kathy Vogt was the senior research fellow who's busy writing up all the results at the moment. But this was in the wake of COVID. So there was a call from the Burdett Nursing Trust to fund projects to help support nurse resilience. So we decided that we were going to submit a bid to try and adapt Reboot to an online format. Again, it's not controlled, it's quite a small study, single arm before and after kind of feasibility study. But to adapt it to the COVID, I guess, world that we now live in, we've made everything online. So now instead of one long half-day workshop, people come to 2 group workshops a week apart, each of which are 2 hours. So 4 hours of workshops roughly all together. And then after that, there's still the coaching call element. And because we had a bit more room, and I was really keen to do this, we expanded the coaching to being 2 phone calls. Actually, I guess as a bit of a spoiler, what's come out of this from the therapist is that she thinks that 1 is probably better. So we're going to be going back to 1 after this. But anyway, we did so 2 workshops, 2 coaching calls in this particular study. And we evaluated feasibility, acceptability, and potential efficacy. So we're looking at demand, whether nurses actually wanted it, whether they signed up, whether we could then get them through to recruitment, retention, whether we could keep them in this fairly kind of long, multi-part project. And then just looking at questionnaires and interviews, looking at experiences and whether there did seem to be increases in psychological variables or not. So it was a mixed methods evaluation guided by the Kirkpatrick model for evaluating complex interventions. And what we found, it was very similar actually to the very first study of Reboot that we did. So there was demand, there was pretty good demand. So we did it over winter from 2021 to early 2022, a really rough time in the NHS, as I'm sure you're all aware, and yet we still had nurses signing up to this. So there were over 100 people that signed up initially and expressed interest. Of those, 84 consented to participate and 77 attended the first workshop, which is, they're the ones that we counted as proper recruits. So you completed baseline measures and joined a workshop. So out of those 77 that we recruited, 62 completed both workshops and both coaching calls, leading to an overall retention of about 80%, which is really good given the context and the nature of the study, the nature of the intervention. At follow-up, what we found was significant increases in resilience, confidence in coping with adverse events, and also this time we measured depression and burnout and intention to leave, and we found significant decreases in depression, burnout, and intention to leave. So this is what it looked like on the graphs. Again, delighted with statisticians' work here and really just pleased to see this. We found a significant increase in resilience over time, significant increase in confidence, very similar to the first one. So resilience was measured at baseline after the coaching calls, and then again at follow-up, which was about 8 to 9 weeks after baseline in the study. Confidence was measured before the workshops, after the coaching calls, and again at 8 to 9 week follow-up. Burnout, we saw significant decreases. So this was before taking part, after the coaching calls, and 8 to 9 week follow-up, and significant decreases in depression. So here again, baseline after the coaching calls and 8 to 9 week follow-up. And also, I don't have the exact numbers here, but when we calculated it in terms of the number of nurses that were meeting caseness for depression, there was a very significant reduction in the number of nurses who were meeting above the screening criteria for depression before and afterwards. So in terms of the qualitative results, they really echo those of the first study, that people liked the peer engagement in the workshops, and they liked the kind of the opportunity to get that one-to-one time to really embed the strategies with the CBT therapist. And it was a CBT therapist that did all this in this project on the coaching calls. And that there was that synergy between those two different elements. But there was some slight differences. So the first was that because it was online and nurses could come from anywhere nationally, they didn't usually know each other. But in this study, they actually cited that as being a benefit because they liked the opportunity to speak to nurses in different trusts, find out how things were there, what was normal, compare notes, and learn a bit more and kind of widen their understanding of what it is to be a critical care nurse in the UK. But also we found this coming out was that the nurses in this study were saying that not only was it benefiting them, but it was giving them the tools to then act as supporters to their colleagues. So this is a quote from one nurse who took part. She said, "I was sat with one of my nurses who thought they'd made an error. I'm not sure they did, but they were being really hard on themselves. They were ruminating and going over and over and over to a really unhealthy extent. So I brought in some of what we'd done at the workshop and I said, you know, this is what you're doing and it's not healthy. And these are the ways that you can break the cycle." So this brings me nearly to the end, but I guess just to give it a bit of a roundup about what we've done and kind of where things are going. So this was, and again, this is a wonderful slide from Kathy, very good visual, which has helped me to understand things as well. So this was the first study that we did, and we did all these little kind of groups in all these different disciplines. So that was the first study that we did where we found that Reboot seemed to be feasible, acceptable, potentially beneficial, although not controlled. This is the critical care nurses study that we've just completed. And at the moment, we've got a grant from the BMA to test it in medical students. So that particular project is underway at the moment. Recruitment to that is going brilliantly, partly to Becky Talbot, whose name I did see here, who did a fantastic job with making lots of contacts for that. So we're actually over recruited to that, and I'm slightly worried about the numbers on that from an unexpected angle. And we've also just done a little project in trainee surgeons. So this is a PhD project, and this is just looking at the workshops. So we did 3 cycles, just the workshops, no coaching calls in trainee surgeons, and still analysing the data on that. But actually what seems to be coming out of that is that trainee surgeons like the workshops, but they wanted more. And they felt that there was something lacking, which to me is interesting because it indicates that there really is something in having the coaching call, and that's kind of what those participants are saying without really voicing it, although we do need to kind of complete the analysis on that data. But the reason we did that is because people always want less. I find whenever I tell them what's involved, they're always like, oh, no, that's too much, we can't do that. So I thought, okay, well, let's try doing less, let's try just doing the workshop. But I think what the data is telling us is that whilst the surgeons like it, they feel like it's missing something, and I think that that's probably the coaching call. Okay, so that's me finished. Thanks very much.
Thank you, Jude, and if you wouldn't mind stopping sharing your screen, then we can all see each other. Thank you so much to all 3 of you for really insightful and quite different talks, because you're coming at this from a very different perspective. In the first case, supporting surgeons after these adverse events happen, and Judith's talk was very much about how do we prepare surgeons and other people for experiencing these adverse events as they are very likely to do in their careers. So thank you so much for those really helpful, insightful and clear talks. There has been a lot of engagement with them in the chat that you may not have been able to follow. And Angela has been particularly kind of vocal in expressing her views, and probably has some questions in there, Angela, that are really important. So can I come to you first of all to see if there's anything you would like to ask the team here?
No, but I think there's a problem in healthcare overall, in the whole world, you know, and I think there has to be an evaluation what could be done. everywhere there is not enough money for hospitals and healthcare. There's a burden for healthcare workers. People are leaving the healthcare. But I think healthcare is one of the most important things in life, just like education, safety, healthcare. So governments have to put more money in it and a good evaluation, more healthcare workers, more safety, more salary things, coaching. Something is really wrong.
I think you're right, Angela. I think that you've expressed a lot of many people's views, but unfortunately, they're not issues that perhaps we as a team can solve. So we're trying to address some slightly smaller, but more solvable issues. I wonder if, but thank you for raising that point, because I think that context is really important. Samita, would you like to ask a question?
More of a comment, if that's okay. So I'm a consultant psychiatrist, and we did a study similar to Kevin and Helen's presentation, and sort of we've developed a support document via the Royal College. And what I found, what I was struck by is how similar. You see, for us, the adverse event is a suicide or a homicide by our patients. And what I was very much struck by is the similarity between the response after an adverse event. And I suppose surgery and psychiatry are very different fields of medicine, if you want to think about them as the two being at two extreme ends, almost, and yet the response amongst clinicians is very much the same. So I wondered whether there was some value, some merit in various sort of, various subsets of the profession coming together to see whether something could be done, and especially at the medical student level. So I was very pleased to hear what you're doing, Judith, with respect to medical students. So just a comment, really, rather than a question. Thank you.
Thank you. I think, Samita, it did culminate in a question, which was, should the medical professions come together to address this? I mean, I think as probably as psychologists, we've generally looked at quite a broad range of medical specialities and have identified that the responses are very similar across the field, some slight differences, but very generalizable. Kevin, Helen, was there anything you wanted to say in response to Samita's comment?
Just as well to say, well, thank you. And I suppose my comment would be, most of it's the same across the whole breadth of the medical profession. And of course, as we've heard already this afternoon, beyond the medical profession to paramedical and allied healthcare profession. So most of it's the same, but some of it's different. And I bring a personal bias as a surgeon, but it remains my view that there are some specialty-specific factors about this, which are at least worthy of considering if the response is going to be as effective as we want it to be. For me, that means there are some surgery-specific factors, and I think I can argue that there are unique or nearly unique factors in surgery, while still, as I said, the main point here is most of it's the same. Some of it's different, and I see value in some subspecialty nuance here in how we support each other.
I think, can I just add to that? I think I'm a real pragmatist, and so when I joined the Surgeons Wellbeing research team, I'm thinking about how do we get surgeons to actually engage with any kind of support, given that the culture within the profession is absolutely not, don't do that. And it seemed more likely that surgeons would engage with support that was surgeon specific. Now, I mean, that's an empirical question though, isn't it? And we could absolutely look at that, and it might turn out that that's a myth, or that that's something that's changing, and that surgeons would engage with a kind of a pan-profession approach. But our starting point was a very pragmatic we know that surgeons are suffering and they mostly won't engage with anything else. So where do we start from? But I think you're absolutely right. I mean, you know, regardless of profession, we're all just human, and we're going to struggle in mostly in similar ways. But that's why I think, for me, that's why we started from a surgeon-specific place.
Thank you. And a note from Judith's talk that what she found was that people really did appreciate it when the cases that were used and the training was tailored to the particular professional group rather than being generic. Smita, I'll come back to you shortly, but I do want to let Amanda in because she's had a hand up for some time, if that's okay. So Amanda, would you like to ask your question?
I'm working obs and gynae, and I must say 100% agree with Helen and Kevin about some degree of speciality specific support. Because for me, yeah, if I had something like that and the cases that were discussed weren't based on obstetric and gynecology, I think I'd probably get a little bit less out of it than if they were looking at the specific peculiarities of dealing, say, of a mother in labour. And it's all been really great. Thank you. One of the things I want to say is, has this been shared with kind of the managers or the people kind of conducting the patient safety incident investigations? Because we could equip those involved with this resilience, but it'd be interesting. Yeah, I think it'd be good for the people kind of doing the investigations to know of the type of support that the people they're investigating are requiring due to the investigations when an adverse event occurs, in the hopes that that understanding could maybe help them support the person being investigated, or just, yeah, understanding of the negative consequences of investigations, etc.
What a fantastic question, Amanda. And I had written down in front of me, without involvement of others in the organisation, is there potential for these interventions, these great interventions, to be undone? You know, because if you've got this great first responder response, but then the investigator comes along and tells you, yeah, you're a criminal and so on and so forth. Yeah. So how do we manage responder intervention, first responder intervention within the larger organisation? Yeah. And Kevin and Helen, I'm guessing this is something you've had to grapple with.
Yes, and the answer is we don't know how it's going to play out. In the guidance that we wrote with the RCS England, there is specific advice to trust management in the form of the medical director, in terms of them being aware of the programme and in them having responsibility to sort of press the go button, if I can use that phrase. So we hope it will be observed by management, and we hope that management, if they're not motivated by a sympathetic response, they might be motivated by a commercial response, which is that broken surgeons are non-productive and turn out to be extremely expensive. So that if for no other reason than productivity of their hospitals, then it makes sense for surgeons to be supported. That may sound a little cynical. I'm sure they're much more caring than that usually, but it's a great question. We don't know. And the program is launched, and we'll know in a year or so how successful we've been. The way we've set up the referral is that we've encouraged surgeons to refer each other, anaesthetists to refer surgeons, and senior theatre and nursing staff to refer surgeons to the program. So even if the managers don't press the go button, then we hope people will be referred to the program anyway. But it's case unproven at the moment.
Thank you so much. Lisa, we'll bring you in and then we'll come back to Sunita and probably finish at that point. And while I've got the floor, could I just remind people that I'm going to put in the chat the title and timing of the next talk on Thursday, October the 20th, which is about undertaking risk and relational work to manage vulnerability, acute medical patients' involvement in patient safety in the NHS. Over to you, Lisa. Sorry, Lisa, we can't hear you. Maybe if you want to put your question in the chat and we'll come to Sunita in the meantime.
Shall I just go?
Please, yeah.
So I was by no means suggesting that the specialty specific groups or interventions should be taken out and a more general thing introduced in its place, because I don't think that will work. I was just struck by how similar many of the feelings and issues were straight after an incident, and how much as a medical, as a group of not just medical but also clinical staff, I should say. So we did this in nurses and other, social workers, etc., who work in psychiatry, how we all just go into our shells and don't think that there is something out there and need someone to reach out and put their hand out for us to take it. And I thought, I was quite struck. I mean, you think that as psychiatrists or people who work in the mental health field, this would be something that we would do easily, but we don't. And I think, and that's why the suggestion that at a medical student level, if we know, or at a training level, a nursing training level, and at CA level, if we know that these supports are available, then I think we are more likely to access them. So just wanted to come back and say that, Helen and Kevin.
Thank you, Smita, and thank you everybody for engaging with the talk today, to the speakers for really excellent presentations. And this is a topic that certainly needs more research and more work, and hopefully in the next 10 years, every hospital will have a programme to support staff after and before adverse events. Thank you very much.